been today. I was like, Mom, you need to have the kids.
Worth their weight in gold, aren't they?
Yeah, preparing to go live.
I've made myself.
So are you logged onto YouTube at the moment yourself?
Right, let's just get this up. Right, that's better.
Yes, I can see something happening.
Paul, are you back working at the moment?
I am, yes. So, I mean, today I was working sort of from home.
You can see me.
I manage a couple of
Right,
practices
yeah.
where I'm a GP principal, and
Yeah.
How does the background look?
they're adequately staffed, so I can sort of work from. But we're doing a lot of sort of work on telephones now, really.
I was going to say, it's a lot of telephone consultations, isn't it?
The background.
So,
Yeah. I
it's-
wish it would work for us. It just doesn't.
you know, very honestly, yes.
Yeah.
A very dear colleague, the dentist.
I couldn't get it to do like that. It looks like
Yeah, I did it the whole of April, and by the end of it, I thought I can't do this on my own anymore.
Okay.
I mean,
Okay.
it's just giving out antibiotics like they were smarties. I was like, this is not what we were taught to do. Can't do this.
Absolutely.
I'll just do a test with them. Yeah. Okay. Thanks very much. Okay. Thank you. Bye. Hello. Good evening, everyone.
Evening.
Evening.
It's we are now live on we're now live on YouTube, just to let you know. People start joining in a few moments, and I was just doing a couple of tests. I remember sending you a message about how to set the internet and make sure things work well, etc. Well, it just so happened just outside in our street today, we've had the people from Virgin Media digging up the whole road, pulling out all the wires. And I said to them, they've been doing it for a few days, but they are refurbishing all the fiber networks. Vodafone have taken over the contract. So actually they're putting like super high speed internet, but that's going to take time. But in the meantime, there's a lot of roadworks and noise and things going on. And just before we went live, about 15 minutes ago, I lost all the internet.
Oh, yeah.
Wow.
It just totally went. And luckily, because I had a practice session before, did you try that speed thing that I sent you? The speed.
The speed
testing the
test.
speed.
Yeah. I tried it.
You tried it, yeah.
Yeah.
But because what happens is when you try that speed test, once it's done the speed test and it stops, and then there's a little message comes up to say, would you like to change the server?
Yeah.
And you can select. So if your speed is lower, you can select different servers. So whoever's providing you the internet, you'll find a list.
Oh wow. Okay, I didn't see that.
Yeah, you should get a list, and from that you can select it. So the trick is select different ones and find out where you're getting the best signal from, and just leave it there until you want to change it. So you might find that your provider's servers could be up in Oxford, could be in Birmingham. I'm on a Wolverhampton server at the moment.
Well, where are you based?
I'm just in Coventry at the moment, and
right.
I've switched over. It was in Birmingham, but I know due to the population size of Birmingham and it's coming evening time, there's going to be more usage out of it. So I tried I tried about 6 different places, and at the moment the Wolverhampton one is at the high speed.
Fantastic. They still haven't woken up, I work in Wolverhampton, near the area, so.
Yes. And I'll be back in London tomorrow. What do you think of the scenery behind me?
Oh, I was going to comment.
I was going to say, very nice.
I'm just testing it out. I wanted to make it look like it was a window out looking across London.
Could have fooled me.
That's right. So when I said I was in the West Midlands, I thought you might say, "Wow, it's changed a bit." Yeah. So, well, I'm glad that everyone can hear us and we can see each other, which is great. And people are joining us right now. And let's have a look. Yes, there's so far 22 people at the moment who've joined us, and those numbers will keep rising as as we kickstart things on here. I've also had some questions which have come through to me, and I'll put those forward. So what we'll do is we'll kickstart. It's surprising. I mean, I know we've got an hour. It's surprising how quickly that hour passes once we start sort of moving into things. And so what I'd like to do first of all is do a quick introduction. So I wanted to thank everyone for joining us today. We are talking about the NHS and the COVID-19 support that's going in, and it's particularly focusing on the Sikh community and all the hard work that they're doing, but it's also focusing on some of the other aspects which is impacting both the Sikh community as well as the communities outside of that. And you might have obviously seen all the demonstrations with Black Lives Matter, the BAME community. There's just so much going on. In fact, probably too much going on very, very quickly after the Brexit into COVID-19. It's difficult to get your breath with so many things going on. So it's great today to be able to focus on the NHS matters. Although I'm not actually from the NHS, I'm from a business school background. For those of people that know me, I did actually attend King's College Medical School, and I dropped out. I found out it wasn't for me. There were lots of other issues as well at the time, family issues. So actually, I took a sabbatical in order to go back, but I never did. And I ended up in business. And so these days I spend my time doing international advisory work, and as a professor of entrepreneurship. So I work with several universities. And being a member of City Sikhs, it's great to be able to do the occasional webinar with the group. So without further ado, I'd like to introduce everyone, and I think it's probably easier if you just introduce yourself sort of one by one. On my PC, I've got it in order as people join. So the first one to join was Jasmine. If you'd like to tell us a little bit about yourself and what you do, and which area of line you work in. So over to you, Jasmine.
Thank you. Well, good evening, everyone. Thank you, Paul, and everybody at City Sikhs for organising these very useful webinars over the last couple of weeks. My name is Jasmine Basra. I am a dentist who works in the NHS and private sector. I manage 2 dental practices alongside my husband Hardeep. I've been in practice for 13 years now. I really enjoyed the clinical and the business side of dentistry. I am also involved in foundation dental training and have been doing that for a couple of years and have a postgraduate certificate in clinical education. Dentistry is a great career. I've had a great couple of years in practice, and yeah, thank you for having me here today.
Right, thank you for that, Jasmine. I think it's Rohit. Rohit's next.
Yep. Hello, everyone. My name's Rohit Sagoo. I'm a founder of British Sikh Nurses. I'm also a lecturer at City University London, and I lecture in children's nursing. I've been a children's nurse for over 20 years. I was one of the actually one of the first Asian male pediatric nurses in the country. So there's something nice there to celebrate as well. Obviously founded British Sikh Nurses in 2016, which has grown exponentially, and we bridge the gap between the NHS and the Sikh and South Asian community in terms of promoting health and well-being and other aspects around health and well-being.
Right. And you say you do also do some lecturing. What kind of topics? What?
I lecture at City University for Children's Nursing. So we do the BSc Children's Nursing program. Also, I lecture on the MSc program for postgraduate nurses as well. So, you know, obviously when they get to postgraduate to do dissertations, etc. and so forth as well, and research projects.
Right. Okay. Yes. Okay. So thank you for that. Must keep you busy.
Yes, indeed. Indeed.
Yes. Okay. Ranjit, it's over to you.
Okay, thank you. Thank you, Paul. Hi everybody, and thank you for the invitation. My name's Ranjit Singh Maroha. I'm the national lead for equality and health inequalities at NHS England, NHS Improvement, a bit of a mouthful. And so prior to COVID-19, we've been leading on something called the NHS long-term plan, which had equality, health inequalities wrapped in it. It was trying to get you remember the government gave us 20 billion pounds. It was actually trying to use that money effectively to get the system to do more around how we meet the needs of addressing health inequalities. What COVID has highlighted is exactly what we've been saying. So back in February, we probably could have written the script for which groups we knew were going to be adversely impacted by COVID. So my day job got parked, and with a team, we've been leading on all the COVID responses around equality groups and what's happening around health inequalities, making sure the guidance was going out to the system, making sure we were looking at those groups that were disadvantaged, so people living in deprived areas, BME communities. We know men have been adversely impacted, obviously people of a certain age and people with disabilities. So a lot of the reports that you've seen coming, we've been feeding into those work, but we've not been doing that ourselves. We've been making sure we link in with Department of Health, we've been linking in with Public Health England, and even the Race Disparity Unit that links to Number 10. So there's been a whole host of activity that we've been driving to make sure that every aspect of those groups that were being impacted at the time and still being impacted, that when we start to move as the year progresses, that if there is a second wave of COVID-19, that it doesn't continue to impact on those groups that have already been impacted and during phase one. So there's been a lot of activity that we've been driving, and obviously the first phase response was just making sure our hospitals were ready to meet the increased demand at the time. On a personal level, my mum is somebody who had a liver transplant back in 2016, so she's been shielded. So we've been learning from what's been happening and the messaging that she's been getting, and making sure that her mental health and well-being is okay. She's with family, but just making sure she's protected. And me and my husband are NHS responders. So in our own time, we've been trying to help vulnerable people in our community, because it's one thing that you do in your day job, but COVID was very much an impact on communities. So we've been trying to offer that support as well. Okay.
Right. Thank you for that, Ranjit. And we'll just move over to Sukhpal. Dr. Sukhpal, please.
Hi, Waheguru Ji Ka Khalsa, Waheguru Ji Ki Fateh, everyone. My name is Dr. Sukhpal Singh Gill. I am a GP based in Midlands. I practice in Walsall. My journey started with in 2009 when I graduated from University of Birmingham. I always wanted to be a GP. It was a fantastic career. I knew it from the start. Had a short stint in sort of trying to get into ophthalmology, but then marriage happened, and then I sort of followed a path into general practice. I was very fortunate to qualify as a GP and actually fall into a very steep learning curve whilst sort of, taking up a post of an associate medical director for a national APMS services provider. So for those of us who don't know general practice very well, alternative provider medical services is a sort of short, long-term, sort of long form for a type of a contract which is sort of procured out to private providers by the government to run GP surgeries. We started in Phoenix with about 13 practices nationwide, and then sort of, it went into a merger with 48 practices nationwide with the practice group. My wife and I thought we'd had enough of me traveling up and down the M1 and M6. So I took up an opportunity to take up a partnership as a GP principal in Walsall. And at the same time, my trainer was retiring. So I sort of had two practices to manage. This was supposed to be a step down for me. I'm not sure I can quite sort of say it was quite a step down. So that's my sort of career pathway. I am very much interested in medical education. I just like Jasmine, I hold a postgraduate certificate in medical education from the University of Kiel. I'm a GP trainer. We have medical students. We have student nurses in our practices. So we're very sort of pro-education training organizations. Mm-hmm. Over the last 4 to 5 years, I've been involved with the UK Sikh Doctors and Dentists Association. This association was formed all the way back in 1984, following some of the atrocities that sort of, we can still remember to date. There were a number of sort of health professional families who sort of got together and really wanted to get that togetherness and be a single voice in amongst sort of a lot of discord at the time. So over the last sort of 3.5 decades, our organization has been sort of running charitable projects, as well as being a voice for Sikh doctors and dentists. We're now sort of slowly branching out into sort of involving other allied health professionals. And it's fantastic to see people like Rohit Sagu, and as well as sort of, other sort of Sikh health professional organizations really taking on the leadership role and trailblazing ahead and allowing sort of that gap to be bridged, which was there for a very long time and needed to be bridged.
Yes, thank you very much for that. And one of the main things that I've found is that I know generally people in the medical sector as well as the NHS, whether it's private sector or the NHS, always tend to have quite busy schedules. But since the lockdown, how has that impacted yourselves? We've had lockdown for the general public, but from the NHS point of view, there were suddenly hospitals going up, specialist centres. Then there was, the lack of PPE. There's lots and lots of issues, and we would hear that on the news. Well, sometimes on a daily or twice a day. The news was packed with that. In the early days, sort of lockdown from mid-March, sort of onwards. How did it sort of personally affect you? In your workload or affect you personally? Maybe I can just go back to Jasmine regarding that.
So we had to close the practices as soon as lockdown was announced, which meant all face-to-face consultations had to cease. But that didn't stop us having to keep the telephones open and triage from home. But that in itself proved very, very difficult, because I personally, telephone dentistry is not something I was ever expected to do or ever trained to do. So having to pick up the phone, diagnose over the phone, and follow the AAA guidelines, which we were told to give people advice, antibiotics or analgesics, kept me very busy. So there was no lockdown, there was no sort of downtime. And then to add to that, I'm sure people out there would appreciate, with homeschooling and everything else that came with being at home, it was probably twice as hard. So we've had to carry on the practice of dentistry, even though it was via the telephone or giving people advice, asking them to go and get temporary filling materials. We've also had lots and lots of webinars, which we could all attend. I think as a profession, there was a lot going on, whether you were helping in the practice or whether you were doing lots of CPD or improving your clinical skills. I think everybody has kept very busy. Also, at the same time, we've had to prepare to open up the practices. So there has been a lot going on.
And I would imagine a lot of people with DIY work, including myself, you know, I lost a filling about mid-March, and eating something a little bit hard. And when you're in pain for a few days, you know there's been a lockdown, you just have to find alternatives. And I remember something called Sensodyne. I just put that on it. I've forgotten about the pain. I've forgotten all about the pain. And so this is like wartime sort of situations. You know, you have to sort of make do, because we cannot see the enemy out there. It is almost like a war, but we just cannot see the enemy. We can't see the damage. The only thing we can see is people falling ill and going into hospitals, or those that are ill perhaps avoiding going into hospitals. How about your experience, Rohit? What sort of experience have you had over the last few weeks?
It's been a very different experience for me. I mean, firstly, what I want to do is just commend all the Sikh organisations that have stepped up over COVID-19. We've had the likes of Khalsa Aid, Nishkam Swat, Midland Langar Service, providing not just, you know, vital services, not just of food parcels and, you know, to people that are vulnerable, but also we've had, you know, so many other organisations creep up that are now providing PPE for the, you know, hospitals and etc., and making PPE from home. So I think that's been commendable from the Sikh community. We always, I think it's within our blood that, you know, we step up when there's a disaster, and, you know, we tend to those who are vulnerable in a disaster as well. But on a personal note, from my perspective, it's been such a transitional change. You know, one minute you're lecturing in you know, an arena with so many students in there, and the next minute actually all lectures are cancelled. And given that, you know, you're tutoring student nurses, it's really difficult because we were preparing them for going into practice. And eventually, you know, the NMC, our body, authority body at the Nursing Midwifery Council, obviously changed goalposts there, and, you know, we're then training our nurses to go out into practice, to spend 6 months out in practice as well, and, you know, making that transition to go and look after potential COVID-19 patients. So there was a lot of upheaval with that as well, and, you know, a lot of support that we needed to generate for our students as well. I mean, from the perspective of British Sikh nurses, we've done a lot as well in terms of community. We went out just beforehand. We worked with Nishkam Swat. I work with Nishkam Swat. We had a healthcare division with Nishkam Swat that we go out and tend to the health care needs of the homeless. But then we had to then, you know, reconfigure our plans and have protocols and policies that would adhere to COVID-19 precautions, to go out there to tend to the homeless, and then, you know, either consolidate those policies to turn around and say, how best fit do we look after and tend to the needs of other people? So that changed. So working with them, you know, all of that changed, and then working with other organizations to look at, you know, how procedures and policies go with gurdwaras. And, you know, now we've got the reopening of gurdwaras with darshan only. You know, back then in March, it was about closing them, and how, you know, you eventually start closing them, or how do you get hand washing in, and etc. and so forth before closing. So there was a lot of work around that as well, and informing the Sikh community and the South Asian community of, you know, the stuff to wash your hands, to have social distancing. That was difficult in itself. You know, obviously Boris Johnson, the government, and the health secretary brought out the rules, but, you know, we find, I'm sure Sukhpal Singh would agree with me, that bridge, for part of forging that bridge is the language barrier that we have with our older generation in comparison to what we have to the younger generation. They're easily understand English, but the older generation, it becomes difficult. Then we have to translate what the government guidelines are to them. You know, you were getting some horror stories of drinking haldi and that would cure COVID-19. Obviously that doesn't happen at all, but you know, it's trying to bust those myths to turn around saying, no, is exactly what you need to do. You need to adhere to instructions and translating those instructions into Punjabi for our community to understand.
Yes. Well, haldi might be good for your skin, but it certainly won't get rid of COVID-19. You know, but yes, there is quite a bit of disparity between the message going out and what people understand. You know, there were times I'd be in different parts of London and people would be going about their business as normal. Central London was completely empty, but other parts of London, no one's wearing masks, no one's wearing gloves. There would be, for them, it was almost like a holiday period. It was just nice and peaceful, no sort of keeping distance. And it's still going on, you know, still going on right now, particularly in the crowded parts of the UK, whether it's Manchester, Birmingham, or parts of London. But there is certainly a disparity even between those working on the front line. As having spoken to Ranjit sort of about it before, that and getting things like PPE, you know, out to the frontline workers. Can you just explain a bit more about that, please, Ranjit?
Yeah, so whilst I don't lead on the PPE, I do know that internally there's a review that our workforce equality colleagues are leading, because there's a couple of things that are quite very true. So people have seen that whilst we've seen during COVID, we've seen, going back to what colleagues were saying, the kindness of what people have done. And a lot of when the calling came out from our chief executive, Simon Stevens, around people who are in retirement, who had left the nursing profession or medical profession to come back in, if I'm honest, there should have been some risk assessment done there before people came into joining the profession again. What happened was people went straight onto frontline, and there was very little at that stage because nobody knew what COVID was, where it was coming from, how the virus was spreading. That if you look at the report on where we've lost a number of our Asian BME staff and Sikh, very high profile Sikh professional GPs and doctors and nurses, we've lost them to COVID whilst they've been taking up that call and undertaking the call to action. There have been issues, and I can't say where if it was because of PPE or it were lack of PPE or it was because they were exposed and not protected. That bit I'm not sure, and there's investigations are underway on that. What we are able to do now is look at the fact that there is a risk assessment that's out there for all frontline staff. And what we are hearing from the BMA, for example, and some of the other unions is that it's not being applied across the board. It's not being applied to porters, it's not being applied appropriately to doctors, and we've got a team that's actually looking at that at the moment and find out what's going on and why the PPE equipment isn't getting to the places that we need to. But we also know that individual providers are also making contact with local services where they can actually buy in PPE equipment as and when required, similar to I think what the care homes have been doing as well. So there's a number of, and what the review is trying to look at is find out where the equipment, so the PPE equipment has to continue to keep coming in, and then what else we can do to protect our staff who are working on the front line as well. So in terms of what I've seen over the last couple of months has been the real best of what our Sikh staff have been able to do, both in terms of not just helping people to come and help in the front line in hospitals, but they've also done a brilliant job in terms of getting exactly what Rohit was saying, the kindness to the communities. While Gurdwara closed down and people couldn't access any services, we managed, people actually looked after each other's neighbours. The Gurdwara have been serving providing food to their Sangat in the communities. One thing we are also picking up is that whilst we've moved to this virtual way of making appointments, if your Auntie G who lives I'm from Smethwick, and I know that when the Gurdwara were very often the main place where people got sources of information and letters translated. If those services are closed down, where were people going to get that information? How were they making contact with their GP? And, you know, communication has been, not everybody's got a smartphone, not everybody has the funds to be able to download and get Wi-Fi. So what we've been saying to our primary care colleagues is and dentistry and other professions, while she moved to working virtually, not everybody in our community, especially from South Asian background, and English is a second language, how are you communicating with those people? So from a community perspective, we're challenging the system to do more in terms of engaging all patients, and don't assume that people have got good smartphones and be able to make contact. But at the same time, we're also trying to look at our staff within the NHS and make sure that the risk-based assessments are taking place and PPE equipment is provided. And also that there's the non-NHS staff, so people who are working as taxi drivers, working on the buses, working in public transport, more front-facing work, who weren't able to lock down in COVID. They had to continue to work, and the impact that this has had on them. So we're trying to look at it in a number of different ways and trying to get the agencies to do more.
I see. It's yes, it's a tough challenge, and I want to just put it to Sukhpal just now. Is obviously you've got the public, but what about the staff themselves that have been working in the health sector? You know, whether it's the Sikh staff as well as you know, some of the challenges that they've faced. So whether it's the Sikh staff or some of the other staff that have worked, what sort of challenges have they faced in the last 3 months?
It's been extremely challenging. I mean, so we've been on the front line, you know, as the COVID pandemic hit us. And just like Jasmine says, you know, immediate sort of changes throughout, you know, we had to sort of reorganize our systems in a way to sort of risk stratify almost sort of who we were seeing. So throughout the country in primary care, if we talk about that first, we had sort of, you know, a setup of dedicated sites which would see suspected COVID patients. So these are referred to by different names: red hubs, hot hubs. But the idea is essentially to sort of, you know, separate out and utilize the NHS 111 service to almost sort of triage these types of cases to sort of head towards that way. Other practices either became what we call amber hubs or green hubs. So amber hubs see patients who are non-COVID suspected patients, and green hubs are those which just essentially have no patient contact whatsoever. But bearing in mind, even in operating an amber hub, we've got asymptomatic carriers, as has come to light, you know, from data from World Health Organization and whatnot. So part of it has been scary actually, because you know, it's obviously sort of working with these very uncertain times. One of the silver linings, I suppose, in this has been we've probably accelerated IT sort of, you know, development or sort of IT implementation within primary care exceptionally well. So, you know, whereas previously appointments were usually 90% face-to-face and 10% sort of, you know, remote consultations, it's almost done a full flip over. So we're doing a lot more sort of telephone consulting rather than face-to-face. There are still obviously essential services like childhood vaccinations or sort of, you know, which cannot be done remotely. So those sort of continue to sort of carry on as they are. The challenges have been slightly sort of different within the secondary care. So again, a similar kind of sort of risk stratification strategy of even separating A&E departments out from what my colleagues tell me to sort of COVID or respiratory bays and non-respiratory bays. And even sort of you've got dedicated wards which will see those types of patients who you feel are the higher risk ones. Many of my colleagues, certainly from Sikh Doctors Association, we've had sort of ophthalmologists, dermatologists who've contacted us to say sort of, you know, they've been redeployed. It's a very military type of terminology that we've been redeployed to other roles and sort of, you know, helping out on the ward or sort of, you know, even within ITU centers. And you know, a lot of people, you know, you're kind of like just anxious about the whole situation, and secondly, sort of then you're working outside your area of competence. Of course, I mean, with adequate supervision, so you know, everybody sort of had to sort of obviously pull together in this. Fortunately, as we know, I think the NHS has managed reasonably well in terms of dealing with patient demand. Things could have been done better, in just like Sir Ranjit says, in terms of PPE availability, and particularly our Sikh doctors, the ones who sort of, you know, support unshorn facial hair. It's been a recurrent theme, I think, and not even just in our country, but actually, you know, worldwide, about the right type of respiratory protective equipment. And you know, getting that out to our Sikh brothers and sisters. But what we found is certainly a lot of the hospital sort of trusts have been very supportive in this. You know, our Sikh colleagues have contacted either sort of our association, or there's a fantastic organization, the British Sikh Doctors Organization, headed by Gagandeep Singh, who've supported sort of colleagues in the London-based area and sort of up and down the country. And also sort of my colleague, Dr. Sukhdev Singh, who's based in Midlands and the chairman of the Sikh Doctors Association. Sort of, you know, there's been fundraisers raised to sort of, you know, even go to the extent of procuring the right type of kit should that need arise. So I think in the spirit of Sikhi and the spirit of our community, I think everybody's done really well to pull together and support each other really. And it's a very sort of positive thing in the face of adversity. Challenges continue. I mean, I'm sure sort of, Paul, you'll come to some of the questions that are, you know, particularly around this area around sort of, you know, the BAME communities and how they are disproportionately impacted. But I'll not sort of overstep the mark and just stick to the questions you're asking me.
Certainly, yeah. Is there anyone else who'd like to add on that with some of the challenges that people have faced from our community or any of the other communities?
I mean, I would, because in dentistry, we're very much left to our own devices. So whether it's NHS or private, we have to source our own PPE. And having been told to go back to work on the 8th of June when we were supposed to open our practices, I mean, the guidance didn't arrive till the 4th. And this proved a lot of issues for some of our Sikh colleagues, like Sukhpal said, because you can't be fit tested if you've got facial hair. So this is where, for us within the profession, the Sikh Dental Association did like phenomenal work. I mean, they've been instrumental in lobbying the government, the BDA, and they managed to get heard. And as Sikh dentists within the profession, the BDA managed to put into their toolkit guidance for how we could go back to work. So like Rohit said, and like Sukhpal said, it's been amazing because whilst in a crisis, everybody's come together and we've been heard, and it's been a big achievement, because otherwise it was very much, you've got to wait, you can't get fit tested, how do we go back to work? And we have a huge amount of clinicians within the profession from the Sikh background.
Right, right.
Can I just,
yes.
sorry, well, I was just going to say that, so I lead on something called a uniforms workwear policy. There's been a review of what that policy is in light of COVID, and there was this, so I do know that the whole issue around, I think there was one of our Sikh doctors had to end up shaving his beards and obviously going against his religion in terms of hair, just to make sure that because there was some confusion, I think, from my understanding, is that there was confusion of what the guidance was saying. It was very ambiguous, and it was how it was being interpreted. So just as Jasmine and Sukhpal were saying, that you know, there's been really good examples where people have acted really quickly and raised that issue, that it's not the same across the board. But I do know that the face coverings to allow the beard to remain, and even in terms of protection of the turban, is something that NHS England is looking into at the moment. So out of this call, it'd be really good to link colleagues into that review, because we just want to join some of those dots up. So whereas it's maybe working good in some areas, making sure that all our doctors, if they're isolated in different parts of the country, they have a voice, and colleagues then can support them to actually shout out. Because if you're a lone doctor, Sikh doctor in a hospital, and you're scared to raise your voice, then we know that there's other associations that can support them. They're in a better position to speak up and say, look, this is against my religion. I don't think I want to do this. Could you please make sure you adhere to my wishes? And it's making sure that takes place as well. So I have heard it from doctors and dentists, but it'd be good to link them in to that review as well. Thanks.
Right. Yes. Yes. Thank you. So, Paul, did you want to add something? So you raised your hand.
Just what Ranjit said, really. So we've done some obviously sort of work with a Manchester-based consultant, Dr. Rajinder Pal Singh. So his videos have been sort of rife on social media about how he's used a Pilates band as a Tata to actually, you know, pass a fit test. And we've actually had that sort of accepted by NHS England, and it's been published as a case example on their website as to how some of the colleagues can, you know, it's I suppose the fit test, you know, it's more about making the mask fit to your face rather than making the face fit to the mask. So if there can be sort of innovative techniques, you know, employed to actually enable clinicians to have that, to be able to pass that fit test. We're now looking at sort of further work into perhaps some studies to get more people fit tested, more likely sort of the qualitative test, which sort of relies on the individual to subjectively sense whether there's been any sort of smell particles come in during that test. And I think if we can get enough colleagues sort of, you know, fit tests and to pass a fit test with a beard, perhaps we may have a stronger case to then go to the health and safety exec to be able to sort of, you know, look into guidance which frankly is 15 years out of date. So there is active work going on behind the scenes, and, you know, I'll be liaising with the Sikh Dental Association, where, as well as, in fact, the Muslim Doctors Association and the Jewish Medical Association, because these issues are something which impact all of our communities in quite a detrimental way, if not addressed.
Yeah. So, Paul, I want to respond to that. I think where what we're doing is saying that if things have worked well during COVID and they need to change. So going back to your issue about the guidance being 15 years out to date, then what our chief exec has said is, look, scrap it, start again and put in what we do need, because we don't have a virus that's going, we don't have any antibodies at the moment that are going to fight COVID. COVID is here for the long haul. We know that. And so we've got to continue to protect our staff, and we've got to continue to protect our communities. So if there's anything that's worked well, now's the time to just raise your hand and say, look, this has got to change. Just because it was doesn't mean it's like that before. So we have been working with the Muslim Dentists and Doctors Association for work around there below the elbows. So, and I know, but I don't think the voice has been that loud. I'm sure you guys have been shouting. I do get that. I just want to hear more of you in the circles where the infection control groups and what they're doing, making sure that they link in as a priority on this, because what worries me is that, you know, those 100 or so staff that lost their lives, you know, are in an predicament that if we're not careful, that will be, people will still continue to be numbers, and we don't want to see that. What we want to, what we should be able to do is be brave enough to say, look, the NHS, we need to look after ourselves, but the NHS has to look after us because you take that risk every day. So it's been bold enough to be able to put those across to the people who are making those reviews and making those changes during COVID. What we called it COVID recovery, but we're still in COVID, if you know what I mean. Like, as we start to open up our services and open up the NHS, we know that we are putting our staff at risk. But to do that, to take that risk, we've got to make sure that they are protected in the equipment and the job that they do on a daily basis.
Yes, there's certainly a lot of challenges, and I think there's going to be a lot of lessons learned from this period, and not just from the NHS, but there's also people who are non-NHS staff, obviously people in the dental practice, private practices, as well as nursing homes. I was wondering what sort of feedback that perhaps some of you may have had from care homes and other associations which are non-NHS staff.
I mean, from the care home perspective, it's been obviously a bit difficult to get PPE because PPE came on when it first wind of COVID-19. Obviously, PPE was distributed to all the hospitals, and the social services sector, you know, was second fiddle. It played second fiddle to the NHS in terms of it. So it was really difficult to get PPE out there. You know, and it, you know, that's why you've got there was, you know, high rates of death within the elderly population. Those who are residents in the residential home, and that didn't come to fruition or light, you know, until later on, until, you know, just a month ago or a couple of months ago, where they started adding the figures in. So it's really difficult because I think we really have to think about both aspects, not just health, but social care as well. And that's one thing that we really need to look at. And, you know, I'm going to play, you know, Grim Reaper here and turn around and say, actually, we also need to look at our community as well. As the BAME Asian community, you know, our men alone are 3 times higher likely than our white counterparts to actually get COVID-19 and suffer from it. And our females are 2.4 times as likely to get COVID-19 than our white counterpart, white females as well. So we really have to look at these statistics in greater depth with the government report that came, the PHE report that came out today, and about understanding the impact of COVID-19 on the BAME groups. So we really have to look significantly at our own community. We have an underlying health problems of high blood pressure, hypertension, diabetes type 2. You know, there's underlying issues within our community that we need to address. And I think it's organizations like myself and like Sukhpal and Sukhdev and British Sikh doctors that have that momentum to turn around and say we need to get some early tests done, screening tests in our gurdwaras for those who might, you know, be hovering around, you know, on the borderline for diabetes or hovering on borderline for hypertension. We need to get those tests done and get them seen and referred to doctors ASAP so they can be on the right medications and they can be on the right treatment for it as well. And that's one issue that, you know, we really need to scale up and look at. And it is something that we really need, the government really need to think about working in partnership with us as BAME and faith groups as well, and reinforcing that risk, you know, reinforcing the actual fact that, you know, there are risks within our community. And that's what we need to really shout out about and turn around and say, this is what our risks are. And you need to take heed to them and get as many professionals working around the clock for us as well.
Can I just come in on that one, Rohit? You've raised some really valid points, and the report that PHE launched today, the second report, the first one being the data one. Obviously our organisation's looking at that, but what we've been doing in the meantime is going back to our national clinical programs like the diabetes prevention program, and I suppose saying, look, you know, you can't do face-to-face engagements now because obviously you've got to change tact and make sure that, so you can't go to the Gurdwara, you can't go to the faith groups and say here's an event to raise awareness around diabetes, but you still got to do something because we know that the prevalence of type 2 diabetes is high amongst our communities, and it's thinking about different strategies, thinking about different ways of actually engaging and making sure that people stay involved in the programme so that it can actually do some of that prevention work. But it's also those that people who already have diabetes and the underlying conditions and how they are managing their long-term conditions, because we know that you're more at risk if you have the type 2 diabetes and the impact that it actually has. So we've been going back to the programs, national programs, and actually saying, so cancer, mental health, diabetes, coronary heart disease, stroke, and saying, what are you doing differently in terms of your interventions to target and segment down to, so you target down into the BME communities, and what are you telling the systems to do more of? But it is about partnership, working with associations like yourselves, and actually saying, look, you know, you have the respect of the community, you know, there's different ways that you can actually link in. So that's what they're open to at the moment. They're developing some really big campaigns to make sure that they're targeting the communities. I suppose they're coming back to our team to say who should they be linking in with. And we have something called Health and Wellbeing Alliance, which is an alliance of various faith-based organisations and voluntary sector organisations, and they're up and they link in with smaller organisations across the board. So we link in through them, but we know that sometimes that's not enough. There's a lot more that we can actually do. So that's sort of where we are. So there's been the diabetes one, and we've also been doing, I think the report may not highlight this, but we know that from our maternity services, BME women have been impacted in terms of COVID-related deaths because of, there've been maternal deaths because of COVID-related, because women have been worried about follow-up appointments or coming to the hospital where there's COVID patients, so it's actually stopped them from coming in. And I think a lot of that's also down to how we've not been messaging properly, probably to the system, to communities, to say, actually, your hospital may have COVID, but this part of the hospital is safe for you to come in. And people have been staying away from accident and emergency. So if you've had a stroke, we've not known if that person has had the stroke. So there's been a lot of things that have come up that we need to sort of reflect on and do something about. So working with your organisations, it'd be really good to make that contact.
Well, one of the things I wanted to touch on was we're actually we're running good on time. But one of the things I wanted to touch on was the fact that sort of lessons learned from overseas now, but there's more and more questions actually coming in, which I'd like to read. But one certainly, as I travel extensively, although this year obviously haven't, there's no flights to go anywhere. But I travel to Southeast Asia quite a bit, and I get news from right across parts of Asia and other countries across Europe. So the kind of things that they've done to help out in during their lockdown and during in their healthcare system, people like, countries like Sweden who've done very little at all, but slowly now they're all starting to report that the number of cases is increasing, and in some instances there's a second wave coming back. And one of the questions I've just had, as I've probably got about a dozen questions outstanding, but one of the questions I've just had is about the concerns about a second wave, because as people start to relax now, You know, it's lovely weather. We're in the summer. People are a little bit worried about the economy, although that's getting slightly pushed to the back. But the wearing of masks is becoming mandatory on public transport. But in the back of people's mind, is there a likelihood of a second wave, whether it's in the autumn or the cold weather? And should people be really taking that very seriously, or as some people say, it's just another excuse for a lockdown?
Oh, no. We should definitely be taking that seriously, and that's certainly the viewpoint from the health professionals. So I think, as Ranjit said, although we are, supposedly in recovery, part of that actually is now preparation within the NHS for this so-called second wave. I'd like to introduce just two facts actually from the World Health Organization. And both of them relate to asymptomatic carriers who can transmit this infection. So these are patients who do not have a cough, who do not have a change in their sense of taste or smell, and any of the other sort of COVID symptoms, or very non-specific COVID symptoms. And it's known that 40% of transmissions that sort of occur during the COVID pandemic occur from these asymptomatic carriers. It's postulated, certainly in America, whether that is one of the reasons why we had so many sort of care home deaths with care staff sort of, working from one place to the other. The other factor is sort of in terms of, there's around about sort of, 16% of sort of asymptomatic carriers who can sort of transmit this infection. Now, if we look at it in terms of a pandemic and just scale this thing up, we're looking at huge numbers who are now potentially passing on the infection without realizing what they're doing. So all these sort of measures that are sort of coming from the center, they're extremely welcome in terms of sort of the public now being advised to wear face masks or face coverings. Of course, these types of face coverings are different to the masks that we wear in the healthcare setting. Certainly when we're sort of, in the very high risk areas, we'll be wearing masks. And the purpose of that is to actually protect ourselves. And it'll be sort of, with a visor, with an apron, with gloves. The purpose of a face mask in the general public is very much so that they potentially can reduce the risk of transmission onto others. Because these masks, although they're not very good at sort of, stopping our outside viruses coming in, they're pretty effective at stopping that viral transmission outside from yourself to others. So, sorry, go on, Paul.
Yeah. No, I'm just going to say that, well, that's quite an interesting thought. And there is a lot of worry about a second wave, yet other people think it's just scaremongering. And the question... Yes.
Yeah. So inside of the NHS and some of the information you see, it is very scary. And what if you can already see that? So if you look at the two things that I think we're paying attention to, there's the Imperial College trajectory that actually showed when a certain another second wave could potentially hit. But if you look at the R number, and it says that if it goes above 1, you have to then go back into lockdown. And I think last week it was reported that if you look at the number went up in the northwest and the southwest. So what's happening is people are seeing that actually we're starting to come out of lockdown. They're going out to the beach, they're going to different areas. So they're taking the virus into those areas, and we're then having to get, so regions are actually starting to get a little bit of they're getting a bit of increase in terms of where they're having to go back into what could be potentially a second wave in those regions. So that may be isolated. So in the Midlands and London, for example, as much as the people dying of COVID has come down, the increase of people being infected by COVID is still increasing. And on some of it is like 5,000 a day. So the NHS app that's being developed and the track and trace work, we did the quality impact assessment on both of those two, and we raised that actually unless you get your messaging right to communities, that when we come out of lockdown, this is still an epidemic and a pandemic, and we need to do something about it, and communities need to observe the social distancing and social isolation. The danger is that people think that if the country's lifted it up and the Prime Minister said everything's okay, then I can go to my local shop and I can cram into that shop and do lots of shopping, everything will be all right. And no, it isn't, because chances are you could go in there and get infected by somebody who's also thinking the same thing. I think in the PHE report, one of the recommendations in there is about a robust communications strategy to the communities, because if our communities start to think everything's okay and we're not giving the messaging right, because we're putting it across in middle class posh English and only goes to people in the leafy areas, our communities who live in various areas are going to get impacted because the messaging isn't getting to them, and they're believing the stories that it's because it was vitamin D, or I hear some of the false news about, well, it was all made up by the government, there's no such thing as COVID. So people start to buy into those stories. So we need to make sure that people the clear messages are that chances of other countries like Korea, China, where there is blips of second waves, also being, I think it was South Korea that one of the countries went back into lockdown because the numbers started to increase. What worries me is that our level of virus, of people being infected by the virus, is still continuing to rise on a daily basis. So the potential of people getting it and it impacting adversely on certain communities, especially if you've got diabetes and long-term health conditions, could potentially have detrimental impact. And that's what's worrying us at the moment.
Right. Okay. Well, thanks for that, Ranjit. I've just got a couple of more questions I need to ask. One of them, this is a question for anyone on the panel. Someone's asking about who should the volunteer and community groups link with in order to get their voices heard, because they believe that it's those people, you know, at the front end, not getting their voices heard, you know, through the NHS and through government. Are there any links that where the groups could actually get together and then form a voice? This is one of the questions I've just had to come through.
So I can share. I'm happy to share my email with colleagues, Paul, if that's okay, and I can link them into our voluntary sector partnerships colleagues, because that's really where we have regular weekly calls with a range of voluntary sector organisations. And what I've always been concerned about is it's been the same big voluntary sector organisations. And my career started off in a very small voluntary sector organisation as an Asian development worker. Nobody heard my voice. I just had to learn on a podium, get on a podium and shout. That shouldn't be the case in 2020. So I'm happy to link people in to the mechanisms that we've got already, so they can,
Well, that'd be great. Then if you could send me that email, and then what I'll do is I'll share it out for those that require it. Another question has come in, more to do, particularly to do with this, with all this campaigning going on with Black Lives Matter, etc., and about racism. And they're just asking regarding the fact of promotion, succession planning, and things like that. You know, what kind of challenges are there for those that are working in the NHS in order to get promotion? Is it still like the old days? Have things changed?
I mean, I can answer that. I mean, this is why I went from nursing to academia. It was difficult. You know, I've been a nurse for 22 years. I worked for the NHS for 12 and wanted to get up into the ladder and etc. And it was difficult to get up to the ladder. And then hence took a change into academia. I think, you know, with Black Lives Matter, it's shown that we as a BAME community, we're emotionally exhausted now of all the fracas that goes on around racism. We're emotionally exhausted from being picked on. We're emotionally exhausted from being, you know, second best and playing second fiddle to our white counterparts. And I think, you know, it highlights a lot of concerns and inequalities that we have, not only just the NHS, but other companies as well, you know, globally around all companies. And it's time our voice was heard. It's been, should I say the cliche, swept under the carpet for too long. You know, and it's now buried out, and people are now protesting and what they need to protest about for our voices to be heard. You know, my condolences go to Lloyd George and his family for, you know, tragic death, for that circumstance that he went through. But he, you know, at the end of the day, it took a tragic circumstances for us to be heard. And it's not just our fellow Black community, it's the Muslim community, the Chinese community, within the nursing profession, it's the Filipino community that need to be heard as well. I hear horror stories that, you know, there are frontline staff being pushed or bullied onto the front line that are from BAME ethnic backgrounds, and, you know, inadequate PPE, and it's costing their lives. And it's time to stop. It's time for us to have our voice, and it's time for us to be heard.
I think, you know, as we know, sort of from our own scriptures, Manas ki jaat sab ek hai pehchanbo. As a community, you know, essentially equality and diversity has actually been there from the times of our gurus. We're one of the very few, very sort of, you know, very fortunate and privileged communities to be able to lay claim to that. And not only should we be standing for our own community, but also for other communities, and be a voice for the whole sort of BAME sort of population to say, look, this is wrong and this is right. All lives matter. You know, let's move away from these very sort of, you know, historic ways of thinking, and actually, you know, we should show our sort of advancement in our humanity and in our thinking in terms of moving beyond just what somebody looks like. I think I'm enthusiastic, and I'm sort of I'm positive that things are moving in the right direction. You know, certainly we've seen that with a very recent report that's come out from the General Medical Council. You know, that was into sort of refer to fair to refer. So why are BAME communities having a disproportional representation when it comes to be referred for fitness to practice referrals? And there are some really good points of how highlighted in there, and some really good recommendations that have been made. But as we've discussed, I think it takes two to tango. So we all need to engage with these exercises and promote, you know, an equal playing field for our own community and for other communities.
Following on from what Paul just said, in the current crisis, we can see that we can be heard. I mean, taking, for example, the fit testing, all the innovation that's come out of it, and the fact that you can have facial hair and be tested for it and pass after what Dr. Rajinder Pal has done, and the fact that the BDAF put it into their toolkit, goes to show that if you lobby well and work coherently and collectively, you can be heard. And the professional bodies do listen, and we can go forward and carry on with what we're doing, but do it like everybody else would.
I think for me, the issue around, I suppose it's interesting. I think Rohit, I'm with you, and sorry, Jasmine and Sukwala, I'm with you guys as well. But I think having worked in the NHS for nearly over 20 years, my concern on the race side is that whilst the protests happen, everybody mobilises and wants to do something and means well. And this time, I suppose people questioning their white privilege and wanting to look at the consciousness and subconsciousness, how they address race, racism, structural racism, is probably something new. What worries me is that as soon as the protests stop, then do we go back to business as usual and we become an afterthought? So whilst I live in hope that things will change, I think for me, the cause of actually addressing race equality through structural change is something that I would like to be hopeful of, and I champion it on a day-to-day. Every meeting you go to, you're living and breathing it, and then you're seeing it on a day-to-day. So I think there is something about leadership. So we're quite fortunate. Simon Stevens came in, and within a year he put forward and said, why can't, you know, he said, right, workforce race equality standard. Let's get it done, get it out, start getting the systems, monitoring against it, and start affecting the change. So, and out of that, there's a lot of leadership, governance, change. You can see where BME staff are being quickly, especially nurses and doctors, have been sent to disciplinary rather than sitting back and saying, you know, is this an issue that we can support them on, rather than disciplining them over it. And people leaving, like Rohit, people like yourself, Rohit, leaving the NHS is a shame. It would be really good to have somebody like yourself back into the NHS and working at a very senior level, building on your experiences and actually making the change. But I think many of us are exhausted with having to champion it. And I think I always look on, remember when I think many of us all of us on this call are the same age. And when we were all standing on the picket line fighting to free Nelson Mandela back in the 90s and 80s and 90s around apartheid, we remember we were looking at hopeful change then. So when he was released, we wanted to see change in it, and it wasn't an issue for just South Africa, it was an issue for all of us, that actually we're born and brought up in these systems, we're educated in the system, yet we can't get up to CEO level purely because, you know, there's always something in the way that stops us. Now, what happens is we keep getting told that it's because we're not capable of doing the job. And 9 times out of 10, we are capable. We're just not, those systems are holding us back. So if there's anybody on this call and I'm talking to people, please come into the NHS, because the more diverse the NHS can be, the more challenge, and all different levels, the more we all start to chip away and make it an NHS that's owned and working for us, not us working for the NHS. And that's the only thing I'm sort of hoping on. So I'll agree with the essential hope of things can get better.
Absolutely. I think could I just add one little sentence, that I think it's our collective responsibility, all of us. I come from a family where there was no other doctors. I was the first doctor in my family, and I think we owe it to our community and the socially deprived communities to support those children, support those kids. Maybe run projects community-wide to actually encourage children into these wonderful healthcare professions, and give them that sort of stepping ladder to just have that playing field with the other communities' children.
Yeah. Well, I think we've had quite a stimulating discussion, and I did say at the beginning the time will pass through very quickly, and it's coming actually 7:10. We're due to finish at 7 o'clock. There's still lots of questions coming through. I think what we'll probably have to do is perhaps do another session, maybe in a few weeks' time, maybe sometime in July, etc., and see where we are, because now we're just coming out of lockdown. Lockdown is easing from this week, and see what effect that has, maybe in sort of 6 to 8 weeks' time, and see where we are with that, at that moment. One thing I did want to mention to Ranjit is she mentioned that we're all about the same age. I just wanted to let her know I've had a very hard life. I'm actually 21. Just look older. Okay.
Thanks,
well, that's right. So I just look older because of that. Okay. But it's been great talking to you. So, unfortunately, we haven't been able to answer a lot of people's questions, but perhaps we can organise another session that's in a few weeks' time. And I'm very grateful for all the panel giving up their time, and the audience as well, who are still online watching with interest. So, and we don't want to keep people away from their other commitments. So thank you very much. It's been great talking to you. And if anyone's got any other questions we can answer, they can send them to City Sikhs, and then we'll get in touch with the panel and be able to answer them, you know, at that time.
Thank you, Paul.
Lovely. Thank you, Paul.
Okay, thanks very much, and have a good evening.
You too. Thanks.
Thank you. Bye-bye.
Bye.
Bye.